Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. And my name is Joe Caramelli, and I oversee the Grand Round Series for our department. And this year we've had Grand Rounds in a webinar format, and we've had presentations covering different domains over the last several months. And I want to encourage you to do two things today. One is fill out the post-presentation evaluation. We had a problem with that back in February and March, and I just realized this a week or two ago. Something was set such that an individual could complete an evaluation only one time. We've fixed that now, and anybody with the UW Net ID can complete the evaluation many times now. So that's fixed. If you've done an evaluation before, you can do it again now. And then second, write in your comments and questions to the comment box. I'll consolidate those and go through them at the end of the presentation today. For today, preventing suicide attempts and helping individuals recover from attempted suicide are major clinical goals, and which spans diagnoses, populations, and clinical settings. And I think probably many of us saw earlier in this week in JAMA that even though there's been approximately 5% decrease in deaths from suicide from 2019 to 2020, suicide remains a leading cause of death in the United States, with a number of deaths in 2020 similar to the numbers in 2015 and 2016. And recently, a new center started in our department called the Center for Suicide Prevention and Recovery that addresses these points. And the center is directed by Dr. Kate Comtois, a professor in our department, who has over 20 years of experience researching suicide prevention. And some background on Dr. Comtois. Dr. Comtois completed a doctorate in clinical community psychology at the University of Maryland, followed by 4 years of postgraduate training at Harborview Medical Center, along with public health training and health services at the UW School of Public Health. Dr. Comtois then stayed on at UW after completing training and was promoted to professor in 2016. Dr. Comtois' local and national work has focused on suicide prevention, which has included mentoring many trainees, as many as 12 in the last 5 years, in related research methodology on suicide prevention. Dr. Comtois also trains clinicians locally and internationally in clinical practices that reduce suicide risk. Dr. Comtois is leading several studies currently, which will be part of today's presentation. And today, Dr. Comtois will describe her current work in the center, and I'll leave it at that for now. And here's Dr. Comtois.
Thank you so much. I really appreciate your all's interest in our center, and I'm happy to have the opportunity to tell you all more about it. So I just wanted to start, as we do all of our suicide dogs, with a little bit of background on suicide as a major public health and healthcare problem. These are all statistics you are all probably quite familiar with in terms of the scope of the problem that we're seeing in suicide prevention. Oftentimes people know more about the statistics around death by suicide. It's also important to see how many Americans have serious thoughts of suicide and how many Americans attempted suicide, and these are 2019 numbers. As you all know, that over half of all suicides are by firearms, and also that firearm deaths are the majority of those are suicides. This is a national map, give you some context for Washington State, where we are. So you see the rates are pretty high in our Pacific Northwest WWAMI region. We're slightly below, to some extent significantly below our other WWAMI states, but still a good bit higher than other states around the country. This is a new dashboard that has been developed oops, I'm just going to try to move, there we go, has been developed to provide much more rapid data on suicide statistics. This allows us to be able to say something about the numbers of suicide in all the way out into 3/4 into 2020, whereas normally we wouldn't be seeing that data for quite some time. So this has been a real advance, and we are seeing this small decrease at the national level, and locally we're not seeing this decrease, although in part that's because we have a smaller population than the entire United States, but we are sort of hovering in Washington State above the national average. And within Washington State, and this is where I think it relates to some of our WWAMI colleagues, we're seeing the plain number of suicides is highest over here in the urban core. But if you look at the age-adjusted rate per 100,000, and these are 2017 numbers, you can see that the rural town and small town isolated areas have particularly high numbers. I've been working with Dr. Deidre Buchwald and some colleagues in the agricultural community on trying to develop interventions for farmers who are having high rates of suicide that's causing a great deal of concern in the agricultural community. When we think about child and adolescent suicide, we're also seeing very high rates of depression and suicide, big increases over the last decade or so. And to kind of put it into local context, if you imagine, based on the Washington State Youth Survey, an average class of 10th grade students, you can see that we're seeing, we'd imagine that 11 of them have had depressive feelings, 6 have considered attempting suicide, and 3 have attempted suicide. So I think that really, again, puts it into context. And another graph that really brings it home is the increasing mental health volumes at Seattle Children's Emergency Department. And these numbers go through 2019 and have only continued to rise. The other population that we've been giving a lot of attention to is the crisis of Black youth suicide, particularly very young Black children have had a sudden increase in suicides that normally as a group that has been less likely to attempt or die by suicide. And so there's a lot of attention to kind of some of these more nuanced numbers. When you see the overall rates declining, it's really important to know that does not apply to all folks. So what I'm going to do is give you kind of a pretty fast trip through the history and activities of the center. I had to kind of make a choice whether to kind of do a deep dive into a few things or kind of cover a lot, not very deeply. And I decided that our team at CSPAR is doing quite a lot of stuff, and I thought it would be better for you guys to have a sense of the scope of the things that we're doing. And I'm happy to follow up with any questions that folks have, or to do a deep dive in any area later if it applies to the work that you do. So kind of our origin story is most of us have been with the department for a while. Some folks are new, coming in on the VA side from the Department of Defense suicide work. And we were somewhat aware of what each other was doing. I was probably more aware than most when you kind of bridge the gap from like the VA to children's. And what we felt, though, was that most of our suicide prevention activities were not very well known by other folks within our department, across UW, or certainly beyond that. And we're all finding that, having individual grants and individual projects, it kind of limits our ability to sort of have leverage in kind of moving initiatives along. So in 2019, we got permission to create a center that represents the suicide prevention work across our department. And while we're not a funded center in the sense of having an independent funding stream, we're all kind of bringing our soft money together, it has really become a common landing point for us. It's a center from which we can speak to folks, potential funders, and also to one of our goals for what was going to be our goal, and then there was COVID. But I think it's kind of a coming goal, and Children's has been enacting it, and the VA too, as well, as to be able to have a positive influence on clinical care around suicide prevention. So just to introduce folks, we have 3 primary sites. The UW Medicine site, most of the 3 of us are more affiliated with Harborview, but thinking about things more from UW Medicine point of view. There's me, which you've already heard about, Rick Reese, who most of you know, is an addiction psychiatrist who's been here in our department leading our addiction psychiatry, and has had a major focus on suicide for a long time. Jeff Sung, who for many years worked with Healthcare for the Homeless here at Harborview, and has been increasingly interested and playing a larger and larger national role around suicide prevention, and particularly around firearms and clinician lost patients to suicide. At Seattle Children's, Molly and Elizabeth are 2 psychologists who've been there a long time, done really cutting edge research, and I'll tell you a little bit about the impact they've had on the Seattle Children's system. At the VA, Puget Sound, both Mark and Larry have come to the VA from the Department of Defense, where they did showed a lot of leadership in the suicide prevention area, and have now brought all that expertise to our VA here in Puget Sound. And we have 2 affiliate faculty, Krista Koo, some of you know, who's now over at Amazon as their expert lead for global HR, and Keeney Law, who is a suicidologist at Seattle Pacific University, who's been collaborating a lot with us. So our mission, this was one of the only times in my career that we actually got to a mission really quickly. Usually this is where everybody kind of bogs down forever. So our mission is to promote the recovery of individuals experiencing suicidal thoughts and behavior, and the effectiveness and resilience of the clinical staff and families who care for them. And we do that through conducting rigorous and ecologically valid research, developing innovative interventions, improving policies, systems, and environments of care, providing expert training and consultation, and listening to and understanding the lived experience of the people who we serve. And in terms of lived experience, we are much more focused on the lived experience of the suicidal individual and the family of the suicidal individual than there's also the lived experience of someone bereaved by suicide, and Forefront has really that's been much more the focus of what they do over in the Department of Social Work, and our focus is more on the lived experience of the suicidal individual themselves. And we also seek a deep understanding of the cultures and settings in which we work that lead to meaningful, pragmatic interventions that are ready for implementation. So real hallmark of all of our work is embedding the work in the settings where it's needed, understanding it culturally, adapting it culturally, so that it has legs and can actually move in the world where we want it to go. So I'm just going to give you a little tour of the UW Medicine site, and then Children's and the VA, and then talk a little bit about some of our other work, but just to give you again, just a taste of the work that we've been doing. For quite some time, since about 2007 or so, we've been looking at the collaborative assessment and management of suicidality. This is a brief outpatient psychotherapy model for treating acute suicidality, acute suicidal ideation, and desire for death. It uses a collaborative model, which is shown here in this example, where we don't on Zoom, but normally would be sitting right next to the patient, examining the factors that drive them to think that suicide is the only option for them, shaping that using the suicide status form, which is shown here on the right, to really drive toward these concepts that are derived from the sort of history and theory of the field of suicidology, and then basing our care on the drivers that are identified from that. We started with a pilot study at the Harborview Mental Health and Addiction Services, and we found positive effects of CAMS over treatment as usual in our intake and brief intervention service, what used to be called the crisis intervention service in those days, where people had a faster improvement and less likely to have rebound. And so that was promising for us. We conducted a study with Dave Jobs in the Army at a military treatment facility on the behavioral health clinic on the East Coast. And we improved the control group to really control for time. We were videotaping them as much as we were videotaping our CAMS clinicians, really strengthening that. And as you find as you strengthen things and as you implement them in an actual clinic, we found smaller differences, but we did find this significant finding that is a lot of what CAMS strives to, which is that by 3 months in, CAMS folks were significantly less likely to have any suicidality on board. And that's one thing that you'll see across a lot of evidence-based practices for suicide prevention is the goal is to get to zero. And in fact, we frequently do. We've just completed a study we're writing up for publication right now where we conducted a randomized controlled trial of CAMS as aftercare from our folks coming off of our inpatient units, primarily at UW and Harborview. And we created a research clinic because of logistical reasons and bureaucratic reasons why we couldn't run it in the mental health center again. But we mimicked everything based on the mental health center. And we had a lot of success in bringing folks in. 91% of people who were randomized on the inpatient unit arrived for at least one session with us, which we thought was really exciting. And we had very few people dissatisfied with the treatment, although you can see a large number of reasons why people left. We found much smaller differences, some small differences at 12 months in suicidal ideation and psychological distress. And again, I think we've done an amazing job to improve the and organize the care for both treatment conditions in the research clinic, and we're able to move people through very quickly. And I feel like the almost more important effect from this was the ability of a research clinic or a suicide-specific clinic to function in our system as a place to discharge clients. And they would stay for us for a few months and then be able to be transferred to primary care or a longer-term mental health program, et cetera. So the system really was, we were very excited about that. We're writing that up for publication now. The other thing that came out of CAMS, as well as work in dialectical behavior therapy, is Jasper Health. So this is a tablet-based intervention that a patient can complete for themselves in the emergency room. You can see that you're offered a virtual guide to walk you through a process of doing a guided interview, doing a lethal means counseling, developing essentially a safety or crisis response plan that is a takeaway. And then there's a home-based app that people can sign up on that all this data gets fed into, and a clinician report that's generated, which I find a really wonderful tool that tells you a lot of information about the patient, gives you some of those core questions you would ask, but also a lot more understanding of what else is going on in driving a person towards suicide and their reasons for living, which I think can bring clinicians a lot closer to, just makes their job easier. And in the pilot work that just came out in 2021, a lot of things you would worry about with Jasper being a tablet in an ER did not turn out to happen. The patients really liked it. They were more likely than significantly more likely to do all the different interventions that are built into Jasper, and they had better outcomes on agitation and distress and ability to cope with thoughts of killing themselves if they participated in Jasper. Jasper is now being implemented in a studied SAMHSA-funded project with the Harborview ER through the Behavioral Health Institute. Another intervention that we've spent a lot of time with is caring contacts. This is a brief intervention that's built on 4 core principles. The first is that the forces that bind us willingly to life are mostly those exerted by our relationships with other people. That regular and long-term contact with another person who expresses caring and concern can be something really critical to keeping somebody interested in living. But that the principle here is that that contact is initiated by the concerned person and puts no demands or expectations on the suicidal person. It's unconditional expression of care, concern, and support. And that such a program, the hypothesis from the start is that this kind of continued contact can exert a long-term suicide prevention influence on high-risk persons, and the particular focus in the development of this intervention is people who can't accept or participate in established healthcare. So this has been studied in multiple trials. And what you can see here is different types of contact. These were letters or greeting cards. How often did the contact? This is in months. So the original study you can see was contact over a pretty long period. Follow-up research has been contact over a year. And the different samples and outcomes. This last row is the study I conducted with Amanda Kerbrat here at UW, where we did use text messaging. We had 11 contacts over the course of a year with active duty soldiers and Marines, and we showed a reduction in the risk of either any suicidal ideation or any suicide attempt during the follow-up year with that intervention as augmenting the care they normally get within the Department of Defense. We're currently conducting other caring contact studies at CSPAR. The CARE project is a partnership with Partnerships for Native Health at Washington State University and 5 Native communities. And we're comparing caring contacts, augmenting best available care in mostly rural reservation Native communities. We're slightly over halfway through data collection. And 2 studies that are just getting started, got a little slowed down by COVID, are PCORI studies that we're conducting with the Ames Center and St. Luke's Health System, looking at caring contacts as a follow-up to the safety planning intervention versus the standard, what we've seen published, you've probably seen in JAMA Psychiatry published the SPI plus. So this is SPI plus follow-up contacts to support the safety plan. There are also a COVID augmentation study looking at caring contacts with and without an initial meeting, which is a really important services question that the St. Luke's folks hope to answer. The third intervention I'll just talk about from UW Medicine is the PARS intervention. This is preventing addiction-related suicide. This is a group-based intervention developed by Rick Reese for use in intensive outpatient programs, which are the most common program for suicide, for addiction that you'll see around. And it's a combination of discussion and didactic material that's secondary prevention. So it's given to all folks in the addiction program. We've just completed a large stepped wedge effectiveness trial, and our hypotheses of improved knowledge, less maladaptive attitudes, and more help seeking were supported in that trial. We're writing that up for publication right now. And I really want to highlight how popular PARS has been within the addiction community and beyond. And these are some of the adaptations that have been in use. So just to move over to Seattle Children's, I really want to highlight the CARES study. This is the Collaborative Adolescent Research on Emotions and Suicide. This is the first trial of DBT versus individual group and some kind of standard treatment. And that was conducted in the US. It's been shown to reduce suicide attempts, self-injury in the initial 6 months, although after the follow-up rates decreased slightly, but this has been a really important study. Recent data has just come out looking at other outcomes that DBT did better on, which I think is also really exciting. And Molly Adrian has done some research looking at some of the moderators and mediators and finding some important differences. This is one example that you can see here in terms of the relative impact on suicide attempts of DBT versus the standard treatment for Latino and non-Latino populations. In addition to that important study, Molly has been also looking at the collaborative assessment and management of suicidality as part of her ARC K-12. She looked across the entire Seattle children's system, what should happen for suicidal kids who are coming in through the system, and what are effective ways to intervene quickly and flexibly within the system. And as you can see, in looking at the adolescents who've moved through the system, that using CAMS has helped the youth to resolve their suicidality, again, working to zero, and response rates that are similar to adults. At the VA Puget Sound site, there's a very large study I know of anybody doing. Mark Rieger's got a grant to evaluate an intervention that he's developed, sending caring contacts through a partnership with the Veterans Crisis Line. The study is targeting 90,000 veterans. I think they may already be close to or exceeding that. And they're looking at different models of caring contacts to see which will have the most benefit, because of course we want the letters to go to everybody. And that's a really large scale implementation study. We're really looking forward to results. In addition, he's been doing research that benefited that trial in terms of veteran preferences. What did they want to see in caring contacts? Evaluating the impact of staff support of caring contacts to increase the implementation of caring contacts for folks in the REACH Vet program, which some of you may be aware, this is the program that uses machine learning, natural language processing models to identify the highest risk veterans in the system. And this is part of the intervention response for them. Mark Rieger's also been working with the Millennium Cohort Study on research there, and that's specific to suicide, and on research related to the transition from military to veteran status. Mark has written one of the most widely cited and important papers in that area. Recently, our UW site has been collaborating with Pat Arian at the Alacrity Center and Creative on technology-based suicide prevention. We have just gotten our pilot study published looking at folks who came through my CAMS clinical trial who agreed to donate their Google data, that's their search data, through a function that Google offers all of us, which is that we can download that data through their takeout program. And we're looking at how that search data functions as a potential warning sign for suicide compared to our gold standard interviews on suicidal behavior. And we just got funded on a large online replication of that study, where we're recruiting folks online with different levels of suicidality. We'll follow them prospectively for a year and examine very closely their suicidal behavior and suicidal thoughts, and see if Google search and YouTube use is a predictor of suicidal behavior. Pat, Arian, and I have also been conducting an online study of suicidality relative to the pandemic, particularly for essential workers and those unemployed due to the pandemic, and describing their suicidal risk and distress, as well as conducting an RCT of different mobile mental health apps as something that will potentially help folks to manage suicide risk and distress. So in addition to research, one of the other things that suicide that CSPAR has been doing for some time is training, and we sort of think of it as sort of along the suicide care pathway. So the thing that's been happening the longest is the DBT training program. It's currently in its 22nd year. The didactics are now co-led by Frida Liu at Seattle Children's and myself, with a lot of help from Adam Carmel and a number of different DBT trainers, and support from Amanda Focht and the outpatient psychiatry clinic, which I very much appreciate. We are in our 8th year of training in CAMS across the department. I do that with Jeff Sung. Amanda Kerbrat has been developing caring contacts training, and there's been a lot of work on Mark's part and others to do that training in the VA. And Jeff Sung has been at the forefront of, no pun intended, training on firearms cultural competency. That is, how well do we as clinicians and how well do physicians in general understand the cultural perspective of folks who are invested in firearms, and how can that partnership be increased, and how can we be more culturally competent in a way that will lead to more effective counseling on regarding lethal means. In addition to the in-person and virtual training that we do at CSPAR, we've been collaborating with the Ames Center on e-learning options. So you can see a number of those listed here, so that we can kind of expand our training beyond that which we can do live. And lastly, I want to talk a little bit about the different impacts that folks from CSPAR have been having on clinical policy and clinical care along the suicide pathway. Nationally, Larry Pruitt and Mark Rieger have been doing a lot of work as it relates to the military and veterans, in getting the voice out there on what is the best ways to collect data, what is the best way to monitor data, what are the best clinical practices that should be implemented across the VA and the Department of Defense. Jeff Sung, as I said, has developed an increasing national presence around several different areas of suicide prevention. In particular, he's done some important guidance for the National Suicide Prevention Resource Center on men in the middle years, as well as what are the best practices that both individual clinicians and agencies can take in response to a patient suicide, and also what do clinicians need after a suicide loss. And he's done a lot of training, and consultation and support for us internally here at UW, but also nationally. He, as I said, has been doing a lot of work in firearm suicide prevention, and both the developing training, but also looking on the policy side, has been working collaboratively to, in our state, the laws have been changed to allow temporary transfer of firearms for suicide prevention. And he wrote a really helpful letter in the American Journal on that process and the important impact to understand as a clinician when it comes to gun transfer, which most of us don't know anything about. Rick Reese, like I said, has been doing a lot of, he's a national expert on suicide prevention and addictions, and his focus in recent years has been on that gray area between suicide and opiate overdose, and we've just submitted a grant to expand the PAR's work in that area. Regionally and locally, you can see some other examples of work that our center has done to collaborate and have an influence on suicide prevention in our region. And then I'd like to really highlight some very important work that Molly Adrian and Elizabeth McCauley others have done at Seattle Children's Hospital to implement a zero suicide initiative pathway, and have really much more systemic process of identifying folks at risk and giving people a clear pathway to follow. And that's been in the process of implementation and expansion across the Seattle Children's system. The other thing that they have learned through their important work on DBT, from DBT and CAMS research, and also this work of figuring out what the system needs at Seattle Children's, has led to this development of a crisis care clinic. This is a really innovative alternative to the emergency room, as well as immediate step-down option following the emergency room, of having 1 to 4 appointments. Both the patient and the caregiver are there. Patients, caregivers, each have their own clinicians, and this has been really important to expand parental support, which has really been missing in the more DBT CAMS kind of model. Help for parents to handle sort of their role in managing risk, but also their grief and loss and distress at having a child who's considering suicide. So they work as a team, meeting both individually, clinician, child, parent or caregiver with their clinician, coming together as a group, implementing these different interventions. And as you can see, this is through their pilot work, they have been showing a positive impact on suicide risk. They've had a lot of success in being able to hand patients off in a successful way, which is something we also see on the adult side, and I think is really an important part of a clinic like this. It's not going to work if you have 4 visits, but then you don't have 4 visits, you have 20 visits or 100 visits. So this has been really an amazing contribution. And of course, the cost is, much lower than what you would see even for one night in the psychiatric unit, let alone the emergency room. And unfortunately, simply limited by staff and resources to offer it to more folks. Folks have been, both the patients and the parents have had a really positive response to this, feel that it is the right approach, and they would recommend it as a response. And with the fact that they can, their priority is to get people an appointment with, in a day or 2 if necessary, certainly within the week. That makes it very different than standard ways that mental health care is being provided in the face of a suicide crisis. And I'm going to segue from that to our big project in development at CSPAR right now. The NIMH has come out with an RFA for a practice-based research center for suicide prevention that we're, a large group of us are submitting. Highlight our collaborative team here between our department and informatics, both folks here at UW Medicine and also at Seattle Children's. And our goal is to really be able to look across the suicide care pathway for primary medical settings and really closely examine, using human-centered design methodology, what are the dilemmas that get in the way, and how can we come up with implementation packages and optimize them to work for primary care settings, with the goal to improve the provider's self-efficacy and the support that the primary medical staff need from mental health. In other words, to get our mental health work to function in much more of a just-in-time fashion, as we saw in the crisis clinic at Children's, and through that to improve care, and through that to improve suicide outcomes, and explicitly to reduce ER referral when that's not necessary. So I have the crisis clinic is our big signature project in this, to be able to implement that and show and optimize exactly what are the components of that program that should be implemented, starting at Children's, but how might we also use that in the UW medicine system, as we did with our research clinic. We're also looking at ways to bring some of the really innovative ideas and systems that people have for identifying suicide risk from, in our case, we're looking at Google. There's social media predictors. There's predictors from the like ReachVet, where they're using medical records and machine learning. There's systems using like the IAT to identify hidden suicide identification. None of these are being used in primary medical settings, or specialty care settings, because you have to make that jump from the work, kind of the how do we actually make that show up in front of a clinician in a useful way. So we're looking at research in that area, research in the area of how do you actually do decision making in a primary setting, and also for people who are not at high risk, but who are being seen in that system, how can we improve the care that they get within the primary medical system, so that overall our primary medical providers, staff, BHIP staff, et cetera, feel that they can handle the suicidal patients in their system in useful ways that prevents kind of ER referral, where there's not that much that can be provided in the ER. Not a lot of times are people getting a lot of care in the inpatient unit that will make long-term change. There's sort of this whole process out here that doesn't always result in the care that you wish it would. And the patient returns to the primary medical setting, and the primary team is in the same boat that they were in before. So that's kind of our goal with that center that we'll be focusing on submitting in June. So that's my tour of our new center. If folks have any questions or comments, we'd welcome them, and please come find us on our website. Our email is the same, uwcspar@uw.edu, and we'd be happy to provide any consultation, training, partner up for research, etc. Thank you.
Thank you, Dr. Comtois. I'd like to encourage participants to write in any questions, comments into the chat. I can go through those with Dr. Comtois and we can hear responses. Well, what a range of areas, practice locations, the new development with the P50 and primary care settings. I can say from my own clinical experience, even as a psychiatrist in primary care settings, often it seems like an ER referral makes the most sense to me, but doesn't make the most sense for the person. And I think having other strategies and other options would be very welcome by the primary care staff and by patients. That's very interesting and exciting. So as people are writing in comments, I wonder, one other thing. I was struck by one of the early infographics about 3 students per 10th grade class attempting suicide. Astonishing numbers. What proportion of those are reported? What do clinicians know about? What do parents know about? Can you talk about that?
I am not a child expert, so probably not as much as you'd like. I would say a lot of this is not reported. We had an interesting conversation yesterday at our faculty meeting around the issue of what happens when I report. And this dynamic and this dilemma we've also been thinking about in terms of the P50 of patient autonomy versus getting help. And so often when help is tied to something pretty high scale, like going to the emergency room. There's a lot of folks who are just saying, I just don't tell anybody that I do this because I don't want to go to the emergency room. I don't want, we think about it as sort of the lights and sirens response. And that's the same feedback we have gotten to date on all of our pilot work, talking to suicidal individuals around the idea of having a Google search metric that would identify that they were in need and what kind of help would they want. And that's been the consistent concern. We saw this in the, we've seen this in other studies where the concern is if the condition of help is that my autonomy is things are going to happen that I don't choose, then I just don't tell.
Mm-hmm. There are a few treatments that are linked to reducing autonomy in a similar way. It's interesting. A question did come in. What is there training being offered to middle and high school counselors, guidance counselors, school counselors to assess for suicide, manage suicide in a school setting?
Yeah, there's training that the Elizabeth and Molly and Aaron Lyon and others have been doing training as part of the training they do with the clinics in our local school system. Forefront over at the social work department also has been doing training with they have a large focus on both the primary secondary schools as well as higher education. So there are some initiatives, and feel free to email us and I'd be happy to get you in touch.
Okay, now two things. One maybe is more straightforward what I think about the other. Anybody using incentives, a point system to increase engagement or improve outcomes in managing suicidal thinking? Maybe like similar. Yeah.
So I would say I can speak to that less from my experience around suicide from my UW work, but in terms of, I do a lot of implementation work on helping systems to implement DBT. And so we do a lot of work with residential facilities, inpatient facilities, et cetera. And one of the things that we really focus on is, can we get them to shift the way that their level system works and their token economies work to reinforce more skillful behavior and decrease reinforcement for more escalated behavior. And I do think it can make a really big difference. But the key is you have to teach the staff to recognize the skillful behavior. Right. So because you can't train the absence of something that you can, but it's not so straightforward. And so if you're going to use a level system or a token economy, you've got to identify what is the behavior that's incompatible with suicidal behavior that you can reinforce. And that I know some folks at Echo Glen had developed an innovative strategy where they gave staff candy they were supposed to carry around with them all day. And the only way to get rid of the candy was to give it to a kid for being skillful. And what ended up happening was, since that didn't happen just naturally enough, the staff began to, first of all, see it in order to get rid of the candy, and also to do a lot more coaching, to do a lot more provoking of skillful behavior. And what they really highlighted was their ability to see it when it happened.
I see. Thank you. A couple of things came in related to social media, digital divide. Do you have concern or are there thoughts about if concerns about digital divide might worsen existing health disparities while working on disseminating interventions?
I think it's a big issue. I think that I'm doing this work, for instance, with the American Indian community, many of whom are living out in reservations or other rural areas where there's very limited data access. And we've actually really needed to prioritize that's part of why we do text messaging research and not mental health app research, is mental health apps are, there's a much bigger digital divide, and in terms of access to the phones that would run the apps, but also access to the wireless connection for those apps. And text messaging has been a better opportunity in those settings. So I think that you do have to think about that really strategically. And at the same time, like with our military folks, where it's really hard to get them to go to behavioral health, there's a lot of stigma, a lot of risk to their career to tell people what's going on for them. They actually do have digital access. And so, moving down an app path makes a lot more sense for them. So I think you have to really consider who you're trying to work with.
Thank you. Another question related to technology. Does the center, or you specifically, do research on social media influencing suicidal thoughts or behaviors?
I don't. I know that I've had a number of colleagues who are involved in the 13 Reasons Why follow-up. People have done studies about the impact of seeing something like that. I think there's a lot of research being done in the area of social media. And I see there's sort of three pathways there. One is this kind of like the 13 Reasons Why idea of like romanticizing or making a big deal about suicide in a way that we see a lot of social media bullying related to suicidality. And then the third is just what we're seeing with social media overall is these increased loneliness, increased sense of disconnection from other people, depression, et cetera, that we're seeing with the increased use of social media that is probably also contributing. Most of that research has actually been done with younger people, and it isn't something we've been doing in our center to date.
Thank you. A question about a specific study. In the IGST versus DBT study, will you perhaps return to that, talk over the IGST arm? Question about the lines not separating much. Would you help us interpret those results?
Yeah, so what you're seeing, and I think that, is something that we're seeing in a lot of clinical trials. When you really do a effectiveness trial, you're not going, there's a lot of control that you want to bring in having a strong control group, because comparing treatment to no treatment, that doesn't tell you very much about the quality of a given treatment. So you want to have that attention control there, and which they did in having both the individual and group treatment in that study. And so what you see is this decline being greater in the orange group, but also seeing a decline in the control group, and we see that across studies. The other thing that's a really big deal with suicide studies is if you don't have a really large sample, then it's very hard to see big differences, because the suicide attempts, there are pretty low base rate behavior. So as much as we fear them, as often as they occur, when you try to actually do a study, it can come down to, 10, in our trial, we had, in Caring Context, we had like 9% versus 15% differences, which is enough to be a significant difference. And it's a pretty small difference. And that's with almost 700 subjects. Not sure if I'm answering.
Is there a follow-up question about Dr. Comtock? Would you highlight key differences between the interventions from this trial?
I think that, again, this is, Elizabeth and Molly's research, so I can only speak to it to the extent that I can. I think the biggest thing is the inclusion of the skills training, happening for the kids and the family, and we can see the parent skills training, effect here. So I think the primary, and what we've seen is that the improvement in emotion regulation is related to why we're seeing the differences between the two conditions. So I think that major focus on well, I think part of it is the skills, which are specific to emotion regulation, but also the idea in DBT that emotion is the thing the needle you have to move, which is unlike standard treatments.
Thank you. We do have several more minutes. If others have questions, please write them in. I do want to ask you a follow-up. You mentioned the low base rate, Dr. Comtois, of suicide. I guess what do you think about that moving forward for improving quality of clinical services? Do you see it more as crisis clinic type model, rapid referral to subspecialty settings within a day or two, or raising baseline quality of all generalist clinicians? Both? What do you think?
Yeah, so I would say a little bit of both. I do think that that there needs to be, what I think of as the synthesis is really more just-in-time care. That having a referral to a clinic you can get in a month from now just isn't what's needed. I think there's a lot of innovative things we could do to provide just-in-time care. So we could be providing just-in-time care as we did, where patients could come to us immediately after the inpatient unit, where you can prevent an ER stay, as Molly has shown with the crisis clinic. I think that there could be more done to, one of my sort of dream ideas is to study the impact of a clinician-led crisis clinic. Like you would call, just like you would call a crisis clinic, except you'd get a licensed clinician. Because I think in the absence of the license, these crisis clinics that have enormous amount of training now and standards for how they do what they do are not considered an alternative for anybody, because those are not licensed clinicians and nobody wants to be the last license to talk to the patient. And I wonder if you just tried a crisis line for a patient to just get on the phone in the primary care doc's office, or even a mental health provider's office, would that be an effective alternative that would allow that patient to go home? I think that there's some ideas around that which could be super helpful. The other thing that what we're seeing across evidence-based practices is that leading with a clinical narrative that is asking the person to please tell you the story of their suicidality before you move in with any interventions. It's showing up across the board on almost all of the different evidence-based interventions. And I wonder whether if we could just reorganize our care to start with the patient telling the story, what you find is almost all those questions you have in your template have actually been answered by the end of the story. So I think we could actually, and people think that the narrative is like just a way of getting something done, but I'm thinking it may actually be an intervention in itself. That ability to reflect on your experience and to reflect on how you coped with suicide may actually prevent people from doing it again.
Very interesting. And I could say, from when I was attending on our hospital service on 7 North, many patients were referred to the Aftercare study, and I remember the immediacy of it. In fact, a clinician came to the unit to meet with the patient before discharge, and there was often an appointment with a day or two after discharge, and it made a lot of sense, and people could get often more rapid specialty care after discharge. Well, thank you for answering questions, the comments on just-in-time care as potential next step, reflection in itself, going through the narrative as a potential intervention. It's very helpful for the audience to hear about your current thinking on this, what you see as future directions. So thank you, Dr. Comtois, for presenting, and thank you to the audience participants, and we can end there.
Thank you so much.
Bye.
Bye.